This is chapter 3, which covers the history of health and healing. Like the first two chapters, I will be introducing some additional material, particularly in this chapter. I'm going to be introducing some material related to epidemiology, the study of disease. And that's just because they make some references to the epidemiological demographic transition without being very clear about what that is. And I just really feel like that's important information for you to know. So to jump in, we are going to first emphasize like this first major point that the chapter makes, like it's in the first couple of sentences, and that is that the history of health is not limited to the history of biomedicine. And so they clarify this at the outset of this chapter to emphasize that, biomedicine, the approach to health that most closely aligns with the health model, as was discussed, with the medical model, as was discussed in chapter 2, the history of biomedicine isn't that long, relatively speaking. But if you look at this more holistic view of health and you consider the traditional approach to health, now, of course, we have a very, very long history of health and healing. And that's kind of the focus that they will be taking in their chapter. And they begin with the MCKEOWN thesis, which is the argument that a lot of the increases in population size that you can see really starting in the early 1900s, a lot of that, he argued, was not due to technological improvements and progress in biomedicine, so it wasn't necessarily because, we created these advanced technologies and surgeries. He made the argument that a lot of this was due to changes in social relations, the economy, living conditions, standards of living conditions. And that was what accounted for this increase in population. And so this thesis is significant because it really aligns with this sociological understanding of health, this social model of health that emphasizes that larger social context when it comes to how healthy a population is, right? Beyond just, the physical body and whether or not that body, has a disease or, disability or something. Now, his thesis is controversial, and I give you a link to an article in case you found this a little interesting and you wanted to do a little bit more reading and study of it. But I think the article has an interesting conclusion, which is basically the thesis, the underpinnings of the thesis, the main argument of the thesis winds up being correct, even if the data that he used was not. His interpretations of it, a lot of other theorists, a lot of other researchers have picked that apart and have some pretty compelling arguments as to why he maybe misinterpreted it or misunderstood it. But the overall conclusion from that bad data analysis, the fact that the socioeconomic conditions of society, probably contribute more to whether or not that society, has a high average life expectancy, a low mortality rate than actual physical, medicine, biomedicine, advances in biomedicine, that argument is more or less correct. So this chapter begins with a discussion of what they call health and healing in deep history. And so this is basically, our early history, before we had writings and records. So this is what we know kind of based on archaeological finds, and what it suggests is that as early as like the New Stone Age, 5,000 years ago, people were using healing crafts and were even doing some crude surgeries. They mention tree panning and amputation, for example. And around this time, we also see, changes in the types of diseases and illnesses people were exposed to and dying from, because around this time is when we switched from a nomadic hunter and gatherer lifestyle to a more settled, agricultural, pastoral lifestyle. Meaning, instead of hunting for food and gathering what was available in nature, we started to stay in one place and raise our own livestock and farm our own crops. And so there was some significant health implications because of this change. The closer lived proximity with animals led to the emergence of diseases that can be transferred back and forth between people and animals. And so, they talked about some of the flus that come out of this now close proximity with livestock, particularly pigs and chickens. Also, being settled in one spot for an ongoing time period led to the emergence of diseases that we refer to as being endemic diseases. And I'm going to talk about what that term endemic means in the next slide. Before I leave this slide, though, just a kind of focus on the idea that, what the book concludes is that what's emergent here during this time is that there's something about the way that humans go about being social and creating new social forms and societies that leads to the type of disease and illness that we see in that society and the amount of disease and illness that we see in that society. So, what's meant by endemic? It sounds awfully like another word that you maybe have heard quite a bit, as we are living through this COVID-19 time, and that's epidemic and pandemic. All of these are terms that come out of epidemiology, which is the study of disease. So I have this really helpful little chart here. Chart A is endemic disease. Endemic disease are diseases that are normal for a given region. There are some regions where a certain amount of a given disease are just normal for that area. For instance, there are parts of the world where, malaria is just much more likely, and a certain amount of cases of malaria per year, I don't want to say is not cause for concern, but once again, let me just emphasize, it is normal, right? It is to be expected. You can count on it year to year in that area. And so that's what endemic, means, is that, there are diseases that are just kind of the norm for that given area. An epidemic is where you see a disease that is either not endemic to the area, or it is happening in a much larger amount number of cases for that area than what we would normally expect, right? So it is the presence of a disease in an area in a much larger amount than what would be expected, or a disease that we would not expect in that area. A pandemic is an epidemic that has spread across multiple areas. So now we have clusters of that disease in larger amounts than what is to be expected. So it's not just sporadic, and it's not endemic, and it's happening, in multiple areas, across multiple regions, across multiple countries, right? So what we saw with COVID, originally, even when we became aware of what was happening in China, there was concerns, right? The COVID-19, it wasn't an endemic. It became very clear that it was an epidemic in China. But then as it popped up in other countries, it became a worldwide pandemic. And in a world where we have, increased global travel and people that, live even in multiple countries and work in multiple countries, and we're so much more interrelated, the fear that epidemics can and will become pandemics, it is in fact a much more legitimate fear than what it would have been 30, 40, 50 years ago, when this type of global travel and global interrelations was much less. And so while we're on this discussion of epidemiology, let me just go ahead and talk about a concept called the epidemiological demographic transition, because your book kind of talks around this, by the end of the chapter without necessarily using this term, but this is certainly what they're talking about. And the epidemiological demographic transition is basically, describes the transition through which a society goes through when they go from having high birth and death rates to low birth and death rates. And in terms of epidemiology, they go from, suffering from acute diseases, which we talked about in a previous chapter, right? Those diseases that, have much faster, much deadlier mortality rates, and faster onset. You catch them, you can't necessarily live with it for a very long time, and then you die from it, right? But so you have societies that go from suffering from these high mortality rates due to acute diseases to societies where now there is a lower death rate. People are more likely to die from chronic diseases, and they're able to live with those diseases, control and manage them for a much longer time period. And so we talk about societies going through this transition. And so let's break it apart. Let's talk about the epidemiological transition first, and then we'll talk about the demographic transition, and just understand that we often talk about these two being kind of coinciding with one another, mapped out on top of one another. So specifically looking at the epidemiological transition, we can think about it in terms of it being 4 stages of the transition. Phase 1, which is called the age of pestilence or infection and famine. What's going on here is that, people get a lot of infections. They're especially prone to them because they oftentimes have nutritional deficiencies. But that is kind of what's driving the high mortality rate, is, this high amount of infections. And then the fact that oftentimes they do not have good nutrition, so they also starve. That's famine. Then at some point, society moves into phase 2. Phase 2, usually there is improved sanitation and improved diet. So infections go down, and people start to live longer. And we call this the age of receding pandemics, right? And they note that, you see this in some developing countries. Then you get into phase 3, which is the age of degenerative and man-made diseases. Aging, people are living longer. People have better lifestyles because the SES of the country as a whole, the economic stability, the kind of general lifestyle has improved. And we mean this in terms of, in terms of their diet, in terms of their living conditions. But some of these degenerative and man-made diseases, we start to see them appear because of this improvement in lifestyle. So diet is improved and you're no longer malnutritioned, but maybe you're eating the wrong things. And, that's leading to things like diabetes and hypertension. People have more income, disposable income. So maybe they're spending it on things like, alcohol, cigarettes, drugs. And so we start to see increases in addiction. And so your chart notes that there, oftentimes when societies are in this phase, this is where we start to see, increases in high blood pressure, smoking, leading to heart disease and stroke, rises in obesity. And then finally we get to phase 4, and this is the age of delayed degenerative diseases. And as the chart notes, this is where a lot of Western countries, including the United States, this is where we fall. because we are now more aware of what is contributing to those degenerative and man-made diseases, we're starting to promote changes in behavior. So, there tend to be reductions in risk behavior in the population because of health promotion campaigns and people starting to take preventative steps. And in these countries, we also start to see increases in new treatment. So our aging population, is much older than what you see in the first three phases. Um, and even though prevalence of some diseases might still be high, mortality related to those diseases is low because of treatment. So how does this relate to the demographic transition? Well, in the same way that epidemiology is the study of disease, demography is the study of population change. And there are four ways in which a population can change, a country's population. It can change in terms of birth rate, how many people are being born, death rate, how many people are dying, immigration, how many people are moving in, emigration, how many people are moving out. So in the same way that the epidemiological transition had four phases, the demographic transition has four established phases and a possible fifth phase that we're seeing in some countries. So stage one in the demographic transition is what we call high stationary. Birth rate is high, usually because people are not practicing family planning. Birth control is limited or perhaps even forbidden. But death rate is high because of that malnutrition and infectious acute diseases that we talked about. So a lot of people are being born, but a lot of people die, and at a fairly early age. So for this reason, that's why we call this high and stationary. The population is stable, but it's a high amount of turnover. Then we have phase two, early expanding, or early phase. Birth rate remains high, usually once again, because those family practices are not being put in place, but the death rate is starting to fall, usually because of increases in living standards and public health and nutrition. And so because of this, because people are still having a lot of babies, but people aren't dying as young or as quickly, the rate of increase of population is increasing, it's expanding. Then we have phase three. This is the late phase of the expanding phase, late expanding. Birth rate begins to fall, and death rate is starting to fall more slowly. So this leads to the increase slowing down. As people are figuring out that because of improved medical care and diet, people are living longer, they're starting to see usually that fewer children are needed. And this is also because a lot of these countries are countries that are now, kind of also going from agrarian to more industrial lifestyles, and the need for a lot of children isn't just not necessarily there, if you aren't working on a farm. And so we call this late expanding. And so the increase is still happening, but it's slowing down. Then we get to what's called low stationary. So kind of like high stationary, it's now stable, but instead of it being high, it's low. And that's because the birth rate is low, but the death rate is low. So population is largely stable. Birth rate is low because of family planning, because of availability of birth control, and because of reproductive technologies that allow people to make decisions about when and how many children that they would like to have. And the death rate is low. Acute disease has been replaced by chronic disease, and chronic disease, of course, is better managed between, by treatments and other types of pharmaceutical, as well as maybe even surgical interventions. That possible fifth, the declining or post-demographic phase, we're seeing that in a few countries, Germany, Italy, in particular, Japan, some people have argued, has kind of moved from phase 4 to phase 5. And that's because while your death rate is low, your birth rate is now very low, meaning it's now dropped below what we call the replacement rate. And that is unique to each country, but that's the number that's the percentage of babies that need to be born in order to match the percentage of people who die, right? And so when it's low stable, it's like a 1-to-1 replacement rate. When it stops being 1-to-1, when you have people, so many people either having small families or no children at all, that the replacement rate is now no longer, that 1-to-1 rate. We now, you're now in a declining, you're in a slow decrease transitional phase. So that's just kind of, as we were talking about the history of health and healing, and how different societies at different periods, prioritize, how they were going to approach health, just kind of keep this in mind. What was also influencing their decisions is where they were in that epidemiological and demographic transition. So now getting back to book material, we now have ancient Greece. A big part of this section of the chapter was talking about Hippocrates and the Hippocratic Oath, or what they call the Hippocratic Corpus. There now is some argument, that maybe he didn't really exist, or if he did exist, maybe he wasn't the only person that wrote the whole oath. It now seems like it's more like an entry in Wikipedia. Different people added different things at different times, during this time period. But what is unique about ancient Greece, it was the world's first recognizable systematic approach to health and healing. They focused on those 4 humors, and I'll have a slide kind of depicting that coming up. And so because they saw your health as being kind of based around these 4 humors, when you were sick or ill, it was about the focus was on restoring balance between these humors. And so what's important about ancient Greek medicine is that it's very much a product of the society from which it came. And I think that's just an important sentence, because last chapter we talked about medical knowledge and the social constructionist nature of medical knowledge. And sometimes it's very easy to see that when we're thinking about in the past, like, oh, okay, the Greeks were big into philosophy. So the fact that they had this medical philosophy, and that's what they based their medical knowledge around, makes sense. But the thing is in 100, 200, 300 years, someone might be looking at our medical knowledge from this time and being like, oh, okay, well, this time period, it was characterized by a trust in technology and a growing reliance on technology. So, of course, they believed in right? But, sociologists would just encourage you to think that, all medical knowledge, because it's constructed by people in that society at that time, is going to be a product of the society from which it comes from. And so this just gives you kind of a sense of the Greek, the Greek humoral system, with its focus on blood, phlegm, yellow bile, and black bile, and how it was associated with different elements and different seasons, and that they would, try to figure out, what humor are you lacking, what humor is overly present, and then how do they restore the other humors so that you would be evenly balanced. That was kind of the focus of that system. Now, the next system that they talked about was in medieval Islam. And just to kind of give you a sense of, kind of that area, I have a map about how during this time period, it spread from just kind of that initial area, which is kind of the pink color, to how it then spread to the orange area, and then all the way throughout the light pink area. So, by the time we reach kind of the end of this time period, which, still fairly early, it's like, 750 AD, it has become a much larger area than what it initially started. And it's worth noting that, the Greek humoral system, as crazy it may sound to us, it didn't really fall out of favor until we reached the 1700s, the Enlightenment. And then it was pretty effectively replaced by the 1800s, when people started to understand germs, and we created germ theory. And it still has some relevance today in alternative medicine. advances to the Greek system did primarily come out of this Islamic world during the 500 to 1000 time period. And your book makes a really strong argument about why it came out of the Islamic world and not Europe. And that's because Europe, as they note during this time period, is going through the Dark Ages. And this time period is characterized by violence. There's a lot of wars and military skirmishes going on, religious doctrine that put more faith and power in the hands of priests as opposed to doctors and medical practitioners. This time period in Europe is also very known for its belief in superstition and magic. And there's still this reliance on traditional folk medicine. So all this is to say is, Europe isn't really contributing much to our medical knowledge. They are not contributing much to the Greek system at this time period. On the other hand, by contrast, the Arabic world is kind of the leading global civilization in architecture, technology, mathematics. Your book notes is during this time that algebra, for those of you who hate algebra, you can thank the Arabic world for that. It was developed during this time period. Philosophy as well as medicine. And that's because, unlike Europe at this time, it is more peaceful. It has, expanded its global reach, geographic reach. And during this expansion, it has incorporated and shown openness to other cultures, which led to the sharing of ideas, which I see I have a misspelling there on my slide, but that should say sharing of ideas. And so during this time, as they've expanded and they've come into contact with other cultures and they have become exposed to their ideas, they wind up translating the Greek text, and then they expand upon them with some of their own philosophies. In particular, your book notes, they develop some of their own ideas and treatments, some of which we still call upon and we build upon today. And for instance, ophthalmology, right? So for all of us that, like myself, that have bad eyes, that wear glasses, that have to go to the ophthalmologist, once a year, that discipline, that study comes out of medieval Arabic, the medieval Arabic world. They wrote multiple texts, and those texts later found their way into Western European culture and influenced some of the thinking about medical knowledge that we later discuss coming out of Europe in the next couple of 100 years. And so, the quote there, what we can gather from Islamic ideas on health and healing is that for ideas to develop and to grow, the social circumstances have to be right. In this case, a relatively open society where ideas and thoughts could be exchanged and debated was vital for both the retention of older healing systems and their subsequent development. So once again, just this continued focus on, this is how medical knowledge comes into place. This is how it comes into being, that real social constructionist, being a society that valued openness, that valued debate, that was willing to incorporate other ideas and beliefs into their system, led to this kind of expansion of medical knowledge. And then finally, the final historical kind of time period that your book discusses is the 1700s. And this is the time period associated with the beginning of modern medicine. And as your book notes, the 1700s was a period of great social change. And they kind of give you three reasons why, two of which they then talk about in more detail and one of which they don't. And those three reasons being the Enlightenment, and I give you a video if you want to go, learn some more about the Enlightenment, the Industrial Revolution, once again, a video for that if you want to do more exploration, and finally the French Revolution. So they talk specifically about the Enlightenment and Industrial Revolution. And Enlightenment is a period that really changed how people perceived, oh my gosh, like I have so many misspellings. My apologies, people. I do know how to spell. Maybe I don't know how to type. But, it has to do with how people perceive society and a lot of great European philosophers come out of the Enlightenment, some of whose names you might, remember from your philosophy or your government classes, people like Hume and Smith, Voltaire, Rousseau. It was a period of optimism that humans could better understand the world. And so that aligned with the development of new scientific methods to understand a lot of things, including the human body. And they thought that this better understanding could also then be, used to then change the world. And so a couple of trends became kind of key during this time period. Observation and experimentation became a key way of gathering data and knowing things. And this is also when they begin mapping and illustrating the human body and its parts. And so in that way, your book notes, this was a move away from the holistic understanding of the body to the mind-body dualism and the mechanical metaphor that we talked about that exist in the medical model. So it's during the 1700s that we start to see these ideas come to the forefront. Now, if the Enlightenment was a change in what people thought, then the Industrial Revolution reflected a change in what people do, because this is where we see a transition from people largely working on farms or in craft industries, meaning, you had some small craftspeople that were making boots and making horseshoes and baking bread. But during the Industrial Revolution, we have the rise of the factory system, where you have people making all those things en masse. And with the rise of the factory system, we have a rise in urbanism. And then, this is also the developing of our capitalist system. And initially, when we have this expansion in urbanism, people living in the cities, moving to the cities to work in these factories, there are very poor living conditions initially. And this certainly contributes to the rise of certain infections and diseases. However, as people kind of learn that living conditions and sanitation are contributing to the rise in diseases, living conditions are reshaped. This is where we start to see some of our, public, sewage systems being put in place, better roads, living conditions where you don't have people living on top of one another in hovels. Even in, hospitals, you start to see this focus on hygiene and sanitation. And they note, that Florence Nightingale was key in this, and that she was able to win people over to this focus on hygiene because she used statistics to prove so. So once again, kind of linking back to the Enlightenment, right? This idea that you're using methodology in order to know things about the world. And so before I wrap this chapter, I'm going to add some just additional material about just, the history of doctors, particularly in the United States, and the histories of hospitals in the US. And so this is just a little additional material for your knowledge. So it's worth noting that, out of the 1700s and the Enlightenment, the development of the medical model, the rise of modern medicine, people were largely in the US learning how to be doctors via an apprenticeship, which is, and I'm sorry, you're literally hearing the lawnmower this going on. Hopefully you can still kind of hear me over it. But up until this point, up until 1850, people are learning via apprenticeship how to become a doctor. And like any type of apprenticeship, this really kind of results in a subjective, we aren't necessarily sure if everyone's getting the same type of education, the same quality of education, what exactly they're learning. So it is very important that, in 1850, when they created the first medical school, this was a big deal, because this meant that there was going to be a systematic way in which we train medical practitioners. And so during this time period, between 1850 and 1900, as we're starting to establish medical education and we're starting to focus on using methodology in order to see, what works, this really does represent a shift away from traditional medicine and more the growing dominance of the medical model and biomedicine. And it's also worth noting that during these early years, as doctors are not necessarily being professionally trained, using a combination of biomedicine, but in a lot of cases using traditional medicine. A lot of medical care during this time period isn't very safe. And as we later will learn from Florence Nightingale, part of this is due to, the lack of hygiene that was involved in the administering of a lot of these traditional medicine treatments. By 1900, doctors have gained control over healthcare. They formed the American Medical Association a couple of years before they formed the first medical school. And the American Medical Association, the AMA, is still significant and thriving today. They really push that medical model. And we talked about this in the last chapter, but biomedicine became the orthodox approach and the one that was closely aligned with science. And traditional and alternative medicine became kind of stigmatized as being non-scientific, and therefore less and less people in the Western world, including the United States, relied on those practitioners. And this is key because, people that practiced traditional and alternative science during this time period were more likely to be women and people of color. So these herbalists, these traditional practitioners, these midwives, they kind of, fell out of use, fell out of favor, and found themselves kind of pushed to the outskirts of healthcare, because it's during this period that we start to see the true establishing of this medical dominance. And aligned with that, doctors became the premier example of a profession, and they enjoyed professional dominance, meaning when you think of medicine, when you think of healthcare, you think of doctors, and that their opinions were deemed as being certainly more accepted, more influential, more right than any other healthcare practitioners. And we talked about this concept of medical dominance last chapter when we kind of discussed to what extent could it be declining. I mean, you could argue that even as it has declined, as patients start to see themselves more and more as consumers who are doing their own research, who are willing to get second opinions, who are in some cases seeking out alternative or complementary therapies, that even though this medical dominance, professional dominance isn't as complete as it once was, I think it's still safe to say that a lot of doctors still have this, and that biomedicine still does have medical dominance over other approaches to health. Aligning with this kind of, quick history of doctors in the US, it's worth noting that, where medicine was happening, right, where it was taking place also has a history as well. The hospital is a fairly modern invention. It really comes out of, the Civil War in the US. So, you think about when that was, the 1860s. Before that, most people received their care in their homes. And at the time, this was actually safer because of those lack of sanitation, lack of hygienic practices that Florence Nightingale later pointed out. So it actually was safer to receive medical care at your home just because of that. Before we got the modern hospital that comes out of the Civil War, the closest things that we had to hospitals were like almshouses, which were places that, that people sent the poor. Because when they were in an almshouse, if they got sick, because they did not have a personal home for doctors to come to, almshouses often set up like these medical hospital wings. But in this way, this is also why early hospitals, public hospitals had this kind of stigma in the United States, because they were associated with poverty. And, because they were not able to pay for care because they were in this almshouse, there was oftentimes this distinction between the deserving poor and the undeserving poor, whether or not they would allow you access to a doctor, whether or not they would call a doctor to come look at you, while you were in this public almshouse, has a lot to do with whether or not they thought, you were deserving or not. Undeserving poor were oftentimes people that, suffered from addictions, alcohol, drugs, people that engaged in what was considered to be depravity at the time. And so a lot of that was, related to premarital as well as homosexual sex. And so if you were poor and it was considered that it wasn't your fault, then you were the deserving poor, and therefore you would then become the deserving sick, and you would receive inpatient care. But even being the deserving poor and the deserving sick, there was still this stigma around inpatient care, because the standard at that time was people that had the means received care at homes. And these early hospitals, they were, to use a Goffman term, they were total institutions, meaning they had, you as a patient, you had no rights. They had total control, over your treatment, your course of treatment. And so it wasn't this consumer model that we see today, where patients, do have rights and voices when it comes to their treatment and their care. As I noted, it was during the Civil War that we started to see the development of the modern hospital. And that makes sense just because of, not just the injuries that came out of the Civil War, but also illnesses. And so it just wasn't feasible to be going into people's homes at this time. So, for these soldiers, they created these hospitals that then kind of became the standard, even once the war was over, for what a hospital would look like. And it's worth noting that it is during this time period that Florence Nightingale, that she notices these trends in regards to sanitation, and the hospitals became significantly safer and cleaner, and therefore better results, in the decades post the end of the Civil War. And so during that time, we have what's called the hospital boom. We went from almost 178 hospitals to 5,000 hospitals in just 50 years. And this is the time period between 1873 to 1923. A lot of these hospitals during the hospital boom became, instead of public hospitals, they became for-profit private hospitals, and they offered class-based systems of services, right? So, their health insurance hasn't entered the scene yet. So you kind of get the type of service that you can pay for. The focus on this time is on acute illness, not chronic illness. And it's on surgical admissions, not medical admissions, right? So once again, if it's a chronic illness, or if it's something that's requiring, medical care, and not surgery, this is not what these hospitals were initially used for. And now, of course, you can kind of see that, hospital is kind of a combination of both. There are people in there with acute illnesses, but this is also where people wind up when they have chronic illness problems, related problems as well. And that there are both surgical admissions, but then there are also people that get admitted to hospitals just to receive kind of your, medical care, not related to surgery. And so that's just, I figured I'd give you that little additional history while we're on this history chapter, but that does do it for this chapter.